Creating an environment of trust and safety is an often underappreciated aspect of medicine. Building trust can be crucial to gathering the history needed to make an accurate diagnosis, but may be particularly difficult with patients requiring a medical interpreter, for whom language, legal considerations, and cultural barriers, among other factors, may lead to an incomplete history. This is the true story of one such case.
Mr. M, a 33-year-old man, went to an emergency room in Massachusetts, seeking care after 2 days of nausea, vomiting, abdominal pain, fever, and coughing up blood. Mr. M spoke only Spanish, and through a medical interpreter, he reported no headache, changes in vision, chest pain, back pain, dysuria, rash, or weight loss. Initially, the blood he coughed up was bright red, but now it was dark, like coffee grounds. He also reported a history of smoking 1 pack a day for 15 years, though he had recently quit, and substantial alcohol consumption.
Mr. M's symptoms are concerning. Coughing up blood, or hemoptysis, can be a life-threatening emergency.
On physical exam, he appeared to be in mild respiratory distress. He had a fever and an elevated heart rate. His lung sounds were clear to auscultation. Bowel sounds were normal. There was moderate tenderness to palpation throughout the upper abdomen, but no enlargement of the liver or spleen. There was no evidence of hemorrhage on examination of the nose and oropharynx. The skin appeared normal. A chest radiograph and subsequent computed tomography of the chest were obtained, revealing multifocal, patchy opacities in both lungs. Broad-spectrum antibiotic coverage was initiated, with administration of intravenous vancomycin and piperacillin tazobactam. This was before COVID-19.
Mr. M's rapid heart rate, fever, and respiratory distress are worrisome. The presence of patchy opacities, together with these symptoms, may indicate an infectious process, and administering antibiotics while performing further workup is an appropriate next step. Labs will give us more information.
The sodium and the potassium were low, with evidence of mild kidney injury. Liver tests were abnormal, including elevations in aspartate aminotransferase, alanine aminotransferase, and bilirubin. The white blood cell count was within the normal range, but there was a high percentage of neutrophils. Mr. M was also mildly anemic, and his platelet count was low. The partial thromboplastin time was mildly elevated. Red blood cells were detected on urinalysis, but no white cells or casts were observed. At this point, the patient was given fluids in addition to antibiotics and a proton pump inhibitor, and admitted to the hospital for closer monitoring.
His respiratory symptoms, together with the elevated percentage of neutrophils in the CT findings, suggest pneumonia or aspiration pneumonitis, a lung injury caused by inhaling food, liquid, saliva, or gastric contents into the lungs. Vasculitis, blood vessel inflammation, must also be considered. The elevated partial thromboplastin time indicates a problem with coagulation. This and the elevated liver function test may reflect liver damage from heavy alcohol consumption. The abnormal liver function may alternatively reflect a systemic response to infection. Electrolyte abnormalities can be seen with vomiting or electrolyte loss in the urine. An upper gastrointestinal bleed is not ruled out, but appears less likely. A bronchoscopy would be an appropriate next step to characterize the bleeding.
On bronchoscopy, bloody secretions were seen in the posterior segment of the right upper lobe and the right and left lower lobes of the lungs. Bronchial alveolar lavage, a procedure sometimes performed during bronchoscopy, involves instilling sterile normal saline into a section of the lung, then using suction to collect the fluid sample for further testing. Increasingly hemorrhagic or bloody fluid return with each subsequent sample of instilled saline is consistent with alveolar hemorrhage. Vancomycin and piperacillin tazobactam were continued, and doxycycline was initiated.
The increasing hemorrhagic return on bronchoalveolar lavage identifies the alveoli, tiny air sacs in the lungs where oxygenation occurs, as the source of the bleeding. Diffuse alveolar hemorrhage can present as a complication of many diseases, including infectious causes, autoimmune disorders, and acute respiratory distress syndrome, or ARDS. ARDS is the result of an acute inflammatory state associated with various disease processes, and is characterized by diffuse damage to alveoli and capillaries in the lungs, causing hypoxemia.
Over the next 12 hours, the patient clinically deteriorated. His blood pressure fell and he became increasingly short of breath. New crackles were noted on lung exam. His skin became yellow, indicating a high level of bilirubin. He developed renal failure and required dialysis. He became progressively hypoxemic, requiring increasing supplemental oxygen, ultimately requiring endotracheal intubation and transfer to the ICU. Tests for autoimmune disorders that can cause pulmonary and renal disease, including Goodpasture syndrome and ANCA-associated vasculitis, were negative. There was still no diagnosis. What information was the team missing?
Timely response to a decline in clinical status is critical. Mr. M showed signs of multi-organ failure, including lung, kidney, and liver injury, despite receiving empirical antibiotic therapy for sepsis and pneumonia, including doxycycline to cover possible tick-borne diseases and atypical bacterial pneumonia. The development of crackles on lung examination suggests fluid building up in the air spaces.
The patient's family provided additional history. Mr. M had grown up and lived in a city in central Mexico, with no travel farther south or abroad, before arriving in Massachusetts 4 days before admission. He had entered the country by swimming across the Rio Grande and hiking through the wilderness.
This information is important. Mr. M's arduous journey likely exposed him to unusual pathogens. For example, hantavirus and leptospirosis, both of which can lead to pulmonary hemorrhage and kidney failure, as well as vector-borne diseases must be considered. Malaria and dengue, which can present similarly, are not endemic to the areas Mr. M passed through and are therefore less likely.
A request for serologic test for IgM antibodies to Leptospira species was positive, and a presumptive diagnosis of leptospirosis was made. Serum samples were sent to the Centers for Disease Control and Prevention, the CDC, for confirmatory testing.
The organisms that cause leptospirosis are spirochetes, corkscrew-shaped bacteria that are commonly seen in tropical and subtropical areas, including parts of the southern United States, Puerto Rico, and Hawaii. Livestock, domestic and wild animals may all harbor disease, though rodents are the main reservoir, and contact with their urine or contaminated water or soil can spread the disease. Bodies of fresh water as well as floodwaters can harbor the infection, and Mr. M may have been exposed while crossing the Rio Grande, a freshwater river. More cases of leptospira are anticipated with climate change and associated extreme precipitation and flooding. Mr. M was treated with a broad-spectrum antibiotic regimen that included doxycycline and a penicillin for a total of 2 weeks. The treatment of choice for leptospirosis is a 7-day course of doxycycline in the case of mild disease. Penicillin is used in severe cases. The empirical regimen that he received was considered to be adequate treatment for leptospirosis. The use of glucocorticoids is not routinely recommended, as high-quality evidence of their effectiveness is lacking.
Confirmation of the diagnosis was received from the CDC, and he was discharged 6 weeks later, having made a full recovery. At a follow-up visit 1 month later, he appeared healthy, and all his laboratory tests were normal.
Leptospirosis can be difficult to diagnose, in part because many of its symptoms are common to other diseases, so obtaining a good travel and social history to help pinpoint a possible environmental vector is critical to making the diagnosis and guiding the treatment. Obtaining an accurate travel and social history from a patient is not always possible, such as in a patient who is too young to verbalize or one who lacks mental competence. But clinicians should recognize the importance of a careful history, and that patients may withhold vital and potentially life-saving information if they do not feel comfortable confiding in their care provider. Establishing a sense of confidence and ease in a patient might be one of the most important steps on their road to recovery.